Mm. Over to Lena. You may start.
We'll start now, ma'am.
Yes, please.
A warm good morning to ladies and gentlemen. I think there'll be more joining, but we have to keep up time, so we're starting sharp at 12. Thanks to the Association of Nurse Executives for this platform, which has been given to the Tamil Nadu chapter. It is indeed a time for us to get together, brainstorm, and to put out all our ideas to share with each of you about patient safety and invasive procedures. So we have a lot of work gone into these presentations to empower our nurses, and we are happy to share our thoughts. And also we are happy to listen to any of you if you have your thoughts on the same. This is Association of Nurse Executives India. For those who are not aware of this association, it is an association which was launched in the year 2017, February, under the aegis of Association of Healthcare Providers India, which is AHPI. And we have grown, and now we have a membership of 282 as of date. And we have renowned nursing leaders as a part of this ANI. And there are 15 founding members and executive members, totally making up a number of 30. And 14 states have been a part of Association of Nurse Executives. And we're very happy that this association is growing. And Tamil Nadu is one of the states of ANI. And we are happy to participate and to collaborate with all our nursing leaders across the country. And I hope this presentation would give some empowerment to our nurses at the bedside while they get involved in invasive procedures. I would next move on to introducing our office bearers for the association. We have Thankam ma'am, she is the president of ANI, and we have Clara ma'am, she is the vice president of ANI, and we have Shubhada ma'am, she is the secretary, and we have Ajita ma'am, who is the treasurer of ANI. And we have many leaders who are renowned and who help us out, who guide us, and they also are the founding members of ANI. We are happy to have them as a part of this presentation. Thank you all for joining us, and hope this presentation will empower our nurses. I move on to handing over the platform for seeing Clara ma'am's video. She is the vice president of ANI. She's unable to be with us today as she is involved in an important meeting. So she has sent us her words.
Warm good morning to one and all gathered here. Welcome to Empowered Hour. Today we are going to see about the invasive procedures, how safe it has to be performed in the hospital, and what is the role of a nurse. How empowered is she to deliver a safer care before, during and after an invasive procedure. This is beyond the procedures that are done in the operation theatre. I, Dr. Jyoti Clara Michael, Vice President, Association of Nurse Executive India. Deem it honor to be the advisor for Tamil Nadu Chapter, and I'm very glad that I'm working with Ms. Leena, the President, Ms. Rachel, Vice President, and Dhanlakshmi, the Secretary. I also have Mahalakshmi, who's taking care of engagement and membership committee. So we are very happy that today we are dealing with a subject which is untouched by many webinars and conferences. There are many procedures that are happening in hospitals which is invasive. But how much care are we putting into in considering the safety aspects in this, and how are we empowering nurses? It calls my attention to my experience as a chief nursing officer, and also in the subsequent years as a nursing director. I have seen a couple of incidences that is being discussed in mortality morbidity review meetings, and also in the incident exploration, where we understand that certain things happen related to patient safety. For example, there was an incident when one of the patient was brought to the mortality morbidity review for discussion and exploring the reason for the mortality in him. Why did he become critical and why he was admitted? In this juncture, I just was wanting to reflect only what best a nurse could do. So around the table, every specialist were saying that each one of them probably is not responsible and the other person is responsible for. So finally, I took this on me and my nursing team, and I said, would you all allow me to ensure that next time such occurrences does not happen, and we will ensure safety for all patients going for invasive procedure. So that is the time we realized that what are the important parameters that has to be considered and why nurses have to be the last line of defense.
Thank you, Clara ma'am. Even though you weren't with us, we are happy to hear what is the intent of this talk, and each of us are holding a very big role when it comes to our patients, and when it especially comes to invasive procedures. What Clara ma'am was saying is that we as a team, we thought we'll concentrate on procedures which are done outside theater. So when the moderator speaks, she'll speak more on this. I would like to introduce the Tamil Nadu Nursing Association of Nurse Executives team. We have Ms. Rachel, who is the Vice President, and she is the moderator of this session. She is also the chairperson of the Education Committee. We have Ms. Dhanlakshmi. She is the Secretary of Tamil Nadu Chapter, Annie. And we have our advisor, Clara ma'am. She is at the central level. She is the Vice President. She also advises us the Tamil Nadu chapter. So we're very happy to have these members. And I am Leena, the President of Tamil Nadu chapter. So happy to be a part of this presentation, and I give this stage to our Vice President, Ms. Rachel Roslin, and also she is the Principal of Triple M College of Nursing. Over to you, ma'am.
Thank you, Leena, for that introduction. A very warm good afternoon to all of you. We have started on time, hope to end on time also. So today we are going to lead on patient safety in invasive procedures. So that's the topic which we have chosen for this month to empower our nurses. So we may be wondering, we are talking so much about patient safety and we are having so many audits happening. But why this procedure? This is where many times we fall short of certain happenings and then we tend to miss on. So there are a lot of technological advancements which has played a major role in the latest development in instrumentation, robotics, and imaging. So when we say procedures that require any piercing of the skin to gain access to inside of the patient's body, it can be inserting a tube into a blood vessel or gaining access to a body cavity without cutting the body. It can be any type of scopies or using any type of electromagnetic radiations like laser eye treatments. So all these procedures come into the per se of medical therapeutic and diagnostic investigations which takes place to cure a patient. So it's a huge set of procedures. So we thought we will not concentrate on the happenings in the theater or surgical procedures. We have carefully removed it, and we thought a lot of other procedures other than what is happening in the operation theater we will concentrate today, so that we will be able to empower our nurses, so that where exactly she has to do her pre, intra and post operative care. And nowadays we have the minimally invasive procedures, which is happening at a great surge, where it's a daycare procedures. Our tendency to miss out on certain things when the patient steps in the morning and steps out of the hospital by evening, because a lot of things happen during the daytime. So there exactly the surgeon or the medical team just steps in during the procedure, but the rest of the time is really manned by the nurses. So what exactly are we to do, and where exactly should we say yes, and where exactly we should say no to stop a procedure, and where we have to be watchful. So we have three eminent speakers who are chosen for our presentations today. And we are going to separate our presentation as invasive procedures, which is pre, intra and post. So Professor Sophia Lawrence, who's the professor cum nurse manager, additional deputy nursing superintendent, Christian Medical College, Vellore, is with us, who will be deliberating on the pre-invasive care, what all a nurse has to be empowered in the pre-procedural care. And Professor Sophia has completed her BSc nursing in 1998 and MSc nursing in medical surgical specialty in 2004 from College of Nursing, Christian Medical College, Vellore, with a total of 22 years of clinical experience. She's also a life member of the TNAI, CMAI and EFNI. Member of the audit committee at Christian Medical College, Vellore, internal quality assessor, training program towards national accreditation, NABH assessor, and also an internal quality assessor training program, which was organized by the National Accreditation Board for Hospitals. Now, I'll hand over the session to Professor Sophia, who will take us through the pre-care during invasive procedures, where exactly the nurse has to be empowered. Over to Professor Sophia.
Good morning, ma'am. Good morning for this opportunity. I praise God and thank
Screen, please, full screen and video. Thank you.
Good morning. Thank you, ma'am. I thank ANI and other people, those who have involved and prepared us for this presentation. I'm going to talk about the pre-procedure care and patient safety. It's always better to prepare and prevent, because safety is not a gadget, it's a state of mind. And we should not repair and then repent later what we have missed to do. It's always to have a good preparation so that the patient safety is ensured and patient gets a compassionate, quality and complete care, so that we'll be happy at the end that we have provided a good quality care to the patient, and patient safety is maintained at all the levels of the procedure. The first point that comes to our mind is that when we preparing the patient for the procedure, it is like we have to do the procedure for the correct patient. We have to verify the correct patient, correct type of procedure, correct site or location, correct site, that is left or right side. For an example, for kidney biopsy, when we are looking at the correct patient, nowadays we use identifiers which is now available as a wristband. Even with the wristbands, where the patient unique ID number and the patient name, usually we check and verify, confirm before the procedure is being started for the patient. and the patient number and the name could be manually written, and it could be tied. The tag could be fixed to the patient wrist as a wristband, or even we can nowadays use the technology like RFID tag or barcoding, where manually we don't write or type the patient name and the unique ID. Just the barcoding or RFID tag would be used to identify the patient. So that's also will not miss out anything, that errors that happens while writing or typing the patient's name or unique ID. Correct type of procedure. What procedure that we are going to do? This is the procedure for this patient that we need to confirm. Correct site marking along with the person who is going to do the procedure as per our institution protocol and other national guidelines that we have to, for which are the procedure the nurses can do the site marking. For a kidney biopsy or a lumbar puncture, that where we are going to do it, or for bone marrow aspiration, which sites that we have to do the procedure. We have to be 100% sure that which sites that we have to do. Maybe the other procedure for cardiac catheterization and other things and all, like what type of preparation is needed for a particular procedure, skin preparation, where all that we have to do the skin preparation. So in that way, we have to be very clear that which are the parts need to be prepared, and the site and the location has to be 100% confirmed. And correct site when it comes to the kidney biopsy, for an example, or for the pleural biopsy, where there is a right and left, or it could be of some other procedures like where the site is needed, maybe like a nerve biopsy that has to be taken, maybe a median nerve, whether it could be left hand or a right hand, where we have to be doing it. So in that way, or it could be of a knee, where we are doing some procedures with the knee, right knee or a left knee, okay, where any biopsy is taken. So we have to be sure of the correct patient that we are preparing to do the procedure, correct type of procedure, correct site, location, and correct site, either left or right. So these need to be done correctly. So pre-procedure nursing care includes psychological, physical, and legal. So all these things, the points underneath that I have put in the points, like the first and foremost important thing is obtaining a consent. Consent is not just making the patient to sign, but then we have to identify the correct patient. If the patient is not in the status of giving the consent, or not in the capacity of giving the consent, not in the state of mind, we have some of the capacity for the patient. Should be a GCS should be 50/50, should be able to comprehend, should be able to understand. It should be the major person or the minor, if it's going to be children, that any legal representative that who can give the consent behalf of the patient, or if it could be the old patient, those who are with elderly related complications, maybe a dementia, not able to comprehend, who's a legal representative, has to give the consent. So it should be the patient first and foremost, that we have to give the priority, that patient should be able to give the consent. Or if not, if the patient is not able to give the consent, then we have to move on to the legal representative who was supposed to be giving the consent. It should be of informed consent, not just like signing something what is written. It should be, patient should be able to understand. It should be in the language where the patient can understand, and all the complication doubts need to be clear, whatever the patient is asking. Then the consent need to be got. Procedure, why we are doing it, how it will be beneficial to the patient, and what we are expecting, and what could be the complications or adverse events that can happen. So all these things should be explained to the patient. If the patient completely agreeing and then accepting for the procedure, then consent is obtained, and it is documented for the legal purpose. And check for any contraindication when the patient is going through a particular procedure. If we are doing a procedure like maybe a kidney biopsy, where it is a very kidney is a vascular organ, highly vascular organ. Bleeding is commonly expected. So whether patient is having any PTTT value is less, or on any aspirin, any bleeding disorder patient is having, all these become contraindicated for a kidney biopsy. So we have to check related to a particular procedure, any contraindication is there, and then we have to go ahead in deciding on the procedure. Physical preparation includes like skin preparation, shaving and all those things and all, or taking a betadine bath to prevent an infection, depending upon the procedure. Starvation, bowel preparation for maybe like an endoscopy procedure or a colonoscopy procedure. It starts from 2 or 3 days before how the bowel has to be prepared. Bladder preparation, removal now you are able to hear me, I think.
Yes.
Skin, starvation, bowel and bladder preparation, removal of jewels and the dentures. Maybe when the patient is going for some MRI related procedures, that jewels and dentures, or where there is a moderate sedation is expected, that we have to take off the jewels and the dentures, or when the patient becomes unconscious, that even for the safety of the physical safety as well as the safety of the jewels or the other processes patient is using, that we have to remove it with the consent of the patient. And metal processes is in case of the MRI, which will be contraindicated. So that also we have to keep it in mind. Investigations, results, and images need to be ready before the patient could be wheeled to the procedure room or procedure site. So related radiological and lab investigations, like if the patient is going through some X-ray procedures which is related to where the X-rays are needed, bleeding parameters, scan reports, all things should be ready before the patient is being sent for the procedure.
The screen is not visible.
Yes, ma'am, I identified. I'll again connect it.
Participants, kindly keep yourself muted so that we can hear the content clearly.
And also pre-procedure nursing care includes correct instruments. Maybe like we are going for a lumbar procedure. Now you are able to see the screen, ma'am.
Yes, yes, yes.
Lumbar puncture procedure, what kind of needle is needed? Maybe a bone marrow procedure, whether through cut needle is needed. Maybe it could be a scopy, what kind of scopy is needed, the size and all those things. Whether it is a rigid scopy or it is going to be another scopy. So this is how that we have to keep the correct instruments. It should be calibrated. The functional status of the instrument has to be tested before we could introduce that particular instrument to the patient. Medication administration, or we have to administer certain medication for the procedure, maybe to calm down the patient or for the pain control. Sometimes we have to withhold certain medication when we are going through certain procedure. Maybe like if it is going to be a procedure which could lead to some of the bleeding complication, we have to stop the blood thinner 2 or 3 days or a week back. In that way, we have to withhold some of the procedure. So the need for analgesic. The analgesic cannot be just given just 1 minute or after poking the patient. It should be at least, we should give the onset of the medication to act upon, like maybe an half an hour before the procedure or 1 hour before the procedure, so that the onset of the high peak level will be on when we are doing the procedure, so that the proper pain control will be there for the patient to feel comfortable. Otherwise, patient will be screaming and crying, which will be uncomfortable for the patient, family members, as well as for us to continue to do the procedure. And we have to be careful about anti-anxiety drugs and anesthetic agents, the need and the contraindication as well, that we have to be clear about that. Starting of IV line and fluids when it is needed, because it will be helpful during the procedure and after the procedures, and incision of the catheters, maybe for some of the patients might need after the procedure, edge tube has to be done, or CBD has continuous bladder drainage catheter, urinary catheter has to be inserted. So all those things we have to keep in mind. We have to prepare the patient. Vital signs need to be checked. Maybe if the patient is having any signs and symptoms of infection or contraindications, like the patient is having fever before going on to some of the painful invasive procedure, that we have to inform to the clinician that patient is having fever. Maybe it's not a right time to take the patient for procedure. Maybe the patient is going for some pleural biopsy or thoracentesis, but having a dyspnea. Patient will not be able to hold the breath for some time during the procedure, which might be essential during the procedure. We have to consult and say that it might not be right. Maybe sometimes when the patient is very sick, the patient has to be wheeled to the ultrasonography room or to the some other area where the contract is given, maybe there's some other setting and the patient is not in a position to be now transported to some other setting. So we have to say that it might not be the right time to wheel this patient to the some other setting or to the scopy room or wherever it is. So in that way that we have to keep in mind vital signs and the patient condition has to be assessed before we could send the patient for the procedure. Keep the specimen containers ready so that we will not miss out. Sometimes the clinician might take two container. One, they will send it to the lab, appropriate lab. Some, they will keep it as a reserve. If at all something happens to the first sample, the second sample will be sent. So that for that, we have to check with the clinician and keep the sample container ready. Whether it's going to be one sample container we are going to use or a two sample. Even if the two sample container, the second one, when we are keeping it in the clinical setting, then it has to be discarded. And how long it could be kept in the ward. So those protocol also has to be ready, and we have to be adhered to the protocol. It should not be there lying in the ward for a longer time. If the procedures, that biopsy has to be sent to the lab, and we have to have the record that we have sent it. So all these things before the procedure itself, we have to keep it ready and provide privacy to the patient. I will talk to you about the privacy later, about all the chaperoning and all those things and all. And some of the adverse events that is happening associated with this invasive procedures and other, even the surgical care, is mainly depending upon the poor infection control methods, inadequate patient management, failure to communicate before, during, and after operating procedures. Poor infection control methods is like the cleaning protocol and reuse policy, that when we are using the scopy again and again, how we disinfect, how we clean, and how we reduce and use, what are the personal protective equipment that we have to use to prevent the infection to the patient as well as to the healthcare workers. So those things, inadequate patient management, like what the pre-procedure care that we discussed, and failure to communicate. Most of the time we use some of the jargon when we are talking to the patient. We have to be very simple in our communication. The patient should be able to understand what we are doing it. Even after the procedure, what are the post-procedure instruction the patient has to be following. Those things has to be completely clearly explained to the patient before the procedure itself. Because after the procedure, patient will be in pain, very anxious, just gone through the procedure. So they will not be in a ready mood to listen to what we are saying. So before itself, we have to prepare them even for the post-procedure care. And when we are communicating the occasion, the content, how much that we give to the patient, or patient and the patient relative related to audience, and the purpose that what we are doing. All these things has to be clearly explained to the patient. Then we come to the safety standards, patient's rights and the educational needs of the patient and the family both need to be respected. They have to respect their rights, and for the patient's rights, all the rights of what we have learned, and maybe the refuse, or to have more clear information, or to go for the procedures, or asking doubts, and the family education, what are the things that they want to know, maybe the cost, the purpose, everything clearly we have to explain. And the consent need to be got, which we have already discussed. And safe transfer also is becoming very important, because not all the procedures will be done at the bedside. Maybe to the procedure room in the clinical setting itself, or to the radiological investigation rooms, or to the scopy room, or to the other setting. We might be transferring the patient before the procedure. So we have to follow all the safety standards while shifting the patient. And the stretcher, when we are using the belt, how we are securing the patient and sending even to the wheelchair, whether the wheel is working properly, whether the patient is secured with the belt properly to the wheelchair, and when we transfer the procedure table, whether it's having side rails, or whether it's having the belts for the patient, whether the high and low, that when we are adjusting, whether all the mechanism are working properly, all those things has to be checked before we could place the patient onto the table. And even whether we have to send some of the oxygen cylinder along with the patient, maybe whether it is on flow, it is not stopped. If it's going to be some of the inotropes are very important drugs which are being infused to the patient. IV bags, whether it is properly hanging, it is not kept on the patient thighs or on the abdomen, something and all. Because Once I remember that patient was complaining that all the IV bags and everything, even the infusion pump and all is kept on the patient abdomen, like patient was feeling very uncomfortable. That need to be avoided. We all the time that we have to respect the patient comfort as well. Sedation has to be given preferably on the table, not before shifting the patient. Sometimes in the bed itself, they will give the sedation, maybe some anti-anxiety drugs, and then shift the patient, which will be dangerous. It can lead to fall and other complication. So we have to shift the patient to the stretcher, or some of the sedation has to be given after the patient is transferred to the table. So then only that we have to give the sedation. So that also we have to keep in mind, which will be the very important in the safety point of view. Emergency management preparation also we should be ready, like managing the complications, and also cart trolley has to be ready. If there's going to be any untoward reaction that happens, that immediately the people should be able to do the resuscitation to the patient. And also infection control, like nowadays that we are going through the third wave, even Middle East has started the fourth wave, COVID related now. We have to give important PPEs and doing the COVID test, and patient needs to be negative. If it is going to be a biohazard patient and COVID patient, that when we are doing the procedure, maybe as a nurse that we have to tell that it should be at the last.
Sophia ma'am, sorry to interrupt. I think we are running out of time, ma'am. The other two speakers are also waiting. So
Okay, I'll
please
stop.
Yes, ma'am. Please, please. Yes, ma'am.
Confidentiality has to be maintained at all the time. When it comes to the privacy, the curtains, doors, and windows need to be in a favor of providing privacy to the patient. When the gender-based chaperoning has to be done, we should not expose the female or male patient in a different gender. A male patient is being examined. One male nurse should be there, or some other person should be there. Female patient and a female nurse has to be accompanied along with the person who is doing the procedure. Imaging facility, some of the safety measures include radiation safety program training. Everybody should undergo, and EARB guidelines has to be strictly followed. Display of the sign should be there everywhere so that people can understand. And TLD badges usage, storing, and renewal when it has to be done, and strictly adhere to using the badge, and monitoring has to be done. And using the lead apron and maintenance of the lead aprons, putting it in the horizontal manner, and monitoring for the cracks and things, and disposal has to be done properly. Emergency contact numbers and equipment maintenance also has to be done properly in the radiation safety rooms. And there are some of the checklists available in the link what is provided here that you can go through, like before the procedure and time out and sign out, what are the things that are needed. So it's for just for one procedure that's being given here. For an example, I have shown it. So you can go through the site and you can get a lot of checklists are available. It's better to use a checklist to ensure safety at all the time, so that we will not miss out any point. It should not be a tick one. It should be properly done. It should aid in checking and ensuring safety. So to conclude, I can say that we have to all the time respect the rights of the patient and the family. Good communication is bridge between confusion and the clarity, can bring down a lot of issues that are related to the patient. Consent is valid only when it is informed, not just signed. Complete the checklist before wheeling the patient for procedure so that we will not miss out anything. Transfer safety has to be maintained at all times. Demand for optimal pain management, which is an important thing which nurses has to emphasis onto it. Monitoring the patient is an essential, as performing the life-saving procedure can identify immediately, and we can take appropriate interventions on time. And we have to give importance to the infection control. Germs are not for sharing. It should be prevented. Maintain privacy and confidentiality at all times so that we can respect and provide quality and safe nursing care to the patients. Hope that you can understand. If there is going to be any doubt or anything, maybe after the other people's presentation, we can go ahead. Thank you.
Thank you, Professor Sophia, for taking highlight on the important factors. We will have a question session at the end. Thank you so much. I know the session is, it's a big vast area, and we will highlight on the important points. Now we'll go on to the intra procedures, which Mrs. Janakiram Shanti, who is the Director of Nursing, Kaveri Hospital, Chennai, will be presenting. Madam has completed at Madras Medical College, affiliated to the Tamil Nadu Dr. MGR Medical University, her BSc Nursing, a well-qualified, result-focused and a proven senior nursing professional with extensive experience spanning up to 30 years in nursing and 15 years in the progressive experience at Apollo Hospitals from 2004 to July 2015. And she has completed a Lean Six Sigma Green Belt project and pursuing her Black Belt project in 5S, mentored subordinates on their path to the completion of Green and Yellow Belt programs. She has participated in various quality control programs, completed her NABH internal assessor training, and contributed in the participation in NABH accreditation and surveillance at Apollo Hospitals. And she's committed to the JCAI accreditation at Apollo Hospital. And right now she is working as the Chief Nursing Officer at Kaveri Hospital. Madam, for care. Participants, kindly keep yourself muted. Hannah, can you mute them, please? Is Shanti is here?
Vanakkam and good afternoon to all.
You're not audible, ma'am. Little louder, please.
Vanakkam and good afternoon to all.
Yeah, you're okay.
Thank you for the opportunity given by Annie leadership team and Tamil Nadu team. I'm going to talk about patient safety during intra procedure outside OR. Am I audible?
Yes, yes.
Sorry, 1 minute.
Full screen, ma'am?
Yes.
Yeah, okay.
Invasive procedures that are carried out by medical specialists and radiologists are becoming more widespread. Since 2007, a lot of research had proven that the patient safety is more effective while using procedure checklist. Invasive procedures done, as you all know, in cath lab, radiology department, endoscopy, critical care unit, and also patient bedsides. It is important to promote patient safety during procedures. Few examples of common procedures done in outside the operating room: cath lab, angiogram, PTCA, PPI, thrombectomy, radiology in MRI with sedation, CT guided biopsy, CT angiogram, ultrasound guided biopsy. These are all common procedures, as you all know. In endoscopy, colonoscopy, sigmoidoscopy, upper GI scopy, ERCP, peg tube insertion is most common nowadays. Critical care units, arterial lines, central lines, tracheostomy, ICD, renal biopsy, and intubations. At bedside, lumbar puncture, renal biopsy, pleural tapping, and intubation. Let us discuss about few procedures and nursing errors and the nursing empowerment to promote patient safety during intra procedure. Many incidents were shown in the research, and also we are witnessed during angiogram in the cath lab. Perforation may happen. Patient might go for the bradycardia, ask the person to stop the procedure because it is due to the perforation. Patient may be bradycardia and stabilize and to continue the procedure. Continuous CPR given during procedure when patient got cardiac arrest and there is no evidence of blood flow. As there is no evidence of blood flow, the nurse is empowered to ask the CPR team to stop the procedure. Many times, VT waves seen on the monitor. Nurse is empowered to ask them to stop the procedure as it may lead to risk. Patient developed breathlessness during the procedures. Breathlessness may be due to the pulmonary edema. It is the most common complication seen during the procedures in the cath lab. So you can ask them to stop the procedure, stabilize the patient, and to continue the procedure after stabilization. Witnessed air bubbles is the common one pushed inside. Immediately stop the procedure. It may lead to risk. I'm going to narrate one of the incident where the nurses empowered and to save the life during the procedure in the cath lab. The patient was pre-operative safety ensured and they have taken to the cath lab. On table, during procedure, patient developed little restlessness and tachycardia. The cardiologist was alone and the scrub nurse and the was assisting. The floor nurse cardiologist has to alert the code blue since the patient was becoming sick. When the scenario was happening, they saw there was a nurse from OT walked through that side and seeing some emergency is happening in the cath lab. So she went inside and noticed during her assessment, the bladder was full. So immediately he asked someone to do the catheterization. The nurse took immediately and inserted the K90 catheter and drained 1250 ml of urine. Before the code blue team arrives, the patient was stabilized. So the consultant cardiologist is a very senior person and appreciated the nurse empowerment and her critical thinking to save the patient's life during the procedure. He appreciated given the letter to the management and also the nursing head. In radiology, commonly seen biopsy needles redirected to the wrong site. The nurse has to ask them to stop the procedure and call for the experts. Patient becoming restless during the procedure, she can suggest for some sedation or to stop the procedure. Patient screams due to echo produced during the MRI. The nurse has to tell them to stop the procedure until patient become calm or to continue in case of emergency with the sedation. Prolonging the biopsy procedures under ultrasound guidance suggests for some sedation top-up or take the patient to other area like OT. We can proceed. Patient CT angio images are not seen, was not clear as dye was not administered. We told the procedure and suggest to inject adequate amount of dye. There was a real incident. One of our nurse has taken her mother for CT angio in one of the clinic, where when she went to make the payment in the billing department, by the time the mother was wheeled in without even starting the IV line. So when she realized mother is on the table and the images was not seen, she said, my mother was not started a IV line, stop the procedure. And she allowed them to, after the IV cannulation, to start the process. So this is pre and intra, we need to empower our nurses to check all the safety measures before proceeding the procedure. In endoscopy, commonly seen, patient complaints of pain during colonoscopy, suggests them to increase the painkiller or sedation. Patient goes for a hypoxemia during ERCP, administer the oxygen and connect to the patient in the monitor, stabilize and to take. Patient shows tachycardia during endoscopic procedures. We told the procedures and asked them to check the amount of anticholinergic drugs was infused. Patient has difficulties after mild sedation. Stop the procedure and shift the patient to OT for further stabilization to proceed further. Diagnostic study shows findings of critical outcomes during intraoperative. Immediately stop the procedure and take them to OR to proceed. Patient shows critical deviations on the cardiac monitor during the PEG tube insertion. The nurse has to ask them to stop the procedure, monitor, and stabilize the patient or get the expert's opinion after stabilization and to continue. Patient complaints of difficulty during the upper GI scopy, Stop the procedure and call for the experts. Procedures takes longer than the usual time. Again, withhold the procedure and we have to call for the experts. Let us see about the critical care areas. Commonly done, displacement of CVC lines, emphasized for usage of ultrasound guidance. Failed insertion in invasive lines, ask them to stop the procedure and call for the experts. Inadequate ventilation after tracheostomy, immediately check for the cuff pressure and advise them to change the tube size. Fail to remove guide wire after insertion of invasive lines, insist to remove the guide wire before proceeding further. Multiple punctures is the commonly seen at the same site in the arterial. Ask them to stop the procedure and change the site or call for experts. Difficulty noted during the intubations, ask them to stop and to recommend for the video assisted intubation or experts. In the ward and OPDs, bedside, many occasion lumbar puncture, during lumbar puncture, bleeding may happen. Stop the procedure and assist to continue as it may be due to trauma. Found patient on anticoagulants during LP, stop the procedure and ask them not to continue without the specialist opinion. Difficult in taking renal biopsy using true cut needles when the gloves were not convenient size. It will be very difficult. Sometimes they will be going for a wrong. Many punctures, maybe it can damage the arteries. So ask them to put and ask them to. Difficult pleural tapping was failed for the patient after multiple attempts, call for experts. Difficult intubation at bedside, stop the procedure and ask them to ship the patient to critical care unit. There is a sample checklist. As I said, many studies are evidence that when we use the checklist, safety is ensured. So this is a common checklist, can be utilized in cath lab, endoscopy, at bedside or in critical areas as per the need of the organization. To conclude, safety is the highest priority during intraoperative phase. Nurses are responsible for the excellent clinical outcomes by ensuring the safety during pre, intra and post-operative procedures. If you all are having CSK, that is nothing but communication, skills and knowledge, you all are empowered. There are many references given here for your reference. Thank you.
Thank you, Mrs. Shanti, for highlighting on the intra care during invasive procedures. A lot of empowered areas were highlighted. Time was short. Thank you so much. Now we'll go on to the post-care during invasive procedures. Dr. Lakshmi Ramamurthy, who is the assistant professor at JIPMER Pondicherry, is going to present to us. Dr. Lakshmi has completed a BSc Nursing in 2001 in KG College of Nursing, Coimbatore, Tamil Nadu, and MSc Nursing in Critical Care in 2006 from AIIMS, New Delhi, and PhD Nursing in 2014 from the National Consortium of PhD in Nursing, Indian Nursing Council, and also are recognized as a board of examiners in different universities, member of the Research Monitoring Committee, Ethics Committee, and PhD Research Committee at JIPMER Pondicherry, Puducherry, contributed 4 chapters in different books and organized conferences and workshops. Dr. Lakshmi will now highlight to us about the post-care during invasive procedure. Over to Dr. Lakshmi. Screen is visible, you can start.
Can you see the slides, ma'am?
Yes, yes, it's visible.
Very good afternoon to one and all. I take this opportunity to thank the President and Vice President of DANI and also the Tamil Nadu Chapter for organizing these Empower Hour. Also, I thank for giving the opportunity to me. We know that the invasive procedures are commonly done for the therapeutic and diagnostic purposes. Even with a significant improvement in the patient safety by the safety checklist, still there are gaps. These gaps can be overcome if we empower our nurses to improve the patient safety. Due to the time constraint, I have organized under the few headings. There are a lot of procedures. In this presentation, we'll be focusing on the few procedures, including the cath lab procedures, the radiological procedures, biopsies, aspiration, and intercostal drainage. There are many, but I have listed the important these procedures only due to the time constraints. First, we'll look into the cath lab procedures. We know the cath lab procedures, mainly it is being done for either for the coronary artery disease patient, that is in the form of percutaneous coronary intervention or angiogram, or maybe the electrophysiological studies, or it may be the cath studies. Whatever this thing, the main concern will be the care will be, it is being focused to these areas. So once we receive the patient from the cath lab, make sure that whether the patient, what type of the procedure is being performed to the patient, and what was the contrast or the radiation dose was recorded in the case sheet. Also make sure where is the sheath is being in situ, because nowadays due to the efficiency among the cardiologists, many of them are attempting to do the radial artery, and post-procedure complication is lesser, but still we have to make sure it is where is the sheath is in situ, is it a radial or is it a femoral? Because the sheath removal, the vasovagal effect management is very much important part of our nursing care. When the sheath is getting removed, we should be ready for the managed vasovagal effect. That is a neurohormonal response. Many patients would experience hypotension. So we should be able to take care of that event, and we keep the things, emergency drugs ready to manage that. And puncture site to be assessed. Puncture site mostly for the very caution to be taken if it is a femoral area, because mostly if you see for the interventional procedures, the sheath size would be a little bigger. That is maybe the 7F or the 6F would be, that is 6 French or 7 French is being introduced than the diagnostic procedure, which is commonly the 5 French or 5.5 or 6 French. So when the puncture site is, mostly we'll assess the puncture site for any bleeding or the hematoma. Also we'll assess the presence of the distal pulse. If it is femoral artery is punctured, the distal circulation to be checked for the distal, the limb to be checked for the circulation, that is distal dorsalis pedis pulse to be checked. If bleeding is present and the pressure to be administered, usually after removal of the sheath, there are various mechanisms are available, but commonly nowadays we have the mechanical devices is available. These mechanical devices are applied for the control the bleeding, but make sure that while controlling the bleeding, we should not obliterate the distal pulse. Generally, for all the coronary angiograms, that is when the approach is through the femoral artery, usually it is a minimum of the 6 hours of immobilization. It ranges from the unit protocol. The study supports even from the 4 hours patient can be mobilized, but formally for the arterial puncture, we'll recommend 6 hours of the immobilization. Venous puncture, it is being recommended from the 2.5 hours, we can ambulate the patient. One more important point, that is whenever the patient has come with a sheath into the post-cath unit, when the sheath is being to be removed, always the nurse must ensure ACT, activated clotting time, or the APTT. If it is not in a normal range, normally it will be the 150 seconds for the ACT. If it is more than that, she should always say no for the removal of the sheath, because this patient may end up with the bleeding, and that leads to the hematoma. And she also has whenever notify for the urine output, when the urine output is less than 30 ml per hour, because these patients have received a contrast, this contrast will act as a nephrotoxic. So urine output to be monitored, the post-cath lab, the post-cath procedure room. So when the urine output is less than 30 ml, we have to inform the consultant, notify the patient. That is especially when the patient has a chronic medical renal disease, this has to be taken important part. Other than that, that was for the coronary angiogram and the PCA. Other than that, mostly the patients may undergo in the cath lab the post-implant also we have to take care, that is pacemaker. So when the patient comes with a pacemaker to our post-cath care unit, they restrict the activity on the side of the implant and keep the wound dry, and whatever the discharge, when the patient is getting back, shifted to the ward, and discharge instruction to be given on activity and the voiding of MRI, because this pacemaker get deprogrammed. So the special precaution to be taught to the patient. And very often the patients, when they get admitted with a myocardial infarctions, very often until the permanent treatment is being given, the venous pacing is being done. So when the venous pacing is being done, the nurse must be able to recognize the failure to pace. If you see here in the failure to pace, there is a brief time of no electrical activity. So she should be able to recognize this and check the pacemaker and intimate the consultant. And the next is a failure to capture. If you look at it here, there is electrical impulse is there, but when electrical impulse is there, but there is no capture is there from the patient side. Even though there is a electrical output is being given from the machine, there is no output, capture is there. So this has to be intimated to the consultant. Again, failure to sense. The pacemaker is not recognizing the intrinsic stimuli of the heart. Let us see here, there is an intrinsic stimuli. This is a QRS complex which is being generated from the patient heart. But still, again, immediately the machine gives the impulse. So the machine is not sensing the intrinsic stimuli. So when the nurse observes this kind of the rhythm, she should be able to, in the post-care care unit, she should be able to confirm with the cardiologist or the junior medical staff about this pacing problem. The next is about the radiological procedures. The general care is, it is very important is once the patient, the radiological procedure is ranging from the diagnostic to the intervention. The diagnostic procedures, it may be very minimal, the invasive nature is very minimal. So whatever it is the patient following the procedure, what the patient identification with the two identifier to be done. What was the procedure was recommended and what procedure was performed for the patient. And if it is invasive, that is especially if it is interventional radiological procedure, airway to be ensured because there is a chance for that due to the sedation and the falling back of the tongue, which may lead to the obstruction of the airway, and vital signs also to be checked. And what type of the procedure is being performed? Is it without a contrast or with contrast? Is it interventional or it is a non-interventional? Or is it only diagnostic imaging only? That has to be checked. And what kind of the contrast media is being introduced to the patient and how much was the contrast media? What was the pre-procedure urea creatinine, and ensure the post-procedure whether that particular patient has any chronic medical renal disease history, and in that condition, his urine output and the post-urea creatinine to be taken care. This is a very important part. Nurse must ensure that. And if at all the nurse receives the patient, otherwise she is working in the private diagnostic unit, and do not discharge the patient without a medical staff if at all if the patient has received a procedure with a sedation or the anesthesia drugs, because the private diagnostic unit, what will happen when they shift back to the actual original their own parent hospital, during the transfer time, there is a chances that due to the sedation which has undergone during the part of the procedure, it leads to the complications. So the nurse can always say that better one medical staff should accompany the patient. And if it is interventional procedure, that again radiological procedure, it can be interventional also. If it is interventional procedure, same like a cath lab procedure, puncture site to be assessed and vasovagal effect to be managed and appropriate and pain management. Always the pain management, the nurse can advocate for the patients. Whenever the patient has a pain, the pain optimum analgesics to be advised. And if it is OPD basis, the results must be called to the ordering physician. And also the post-discharge instruction to be given. And the next is about the very common is intercostal drainage incision. This incision part is being taken by the previous faculties. The post-procedure, if you see, when the patients are there following the ICD, never lift the drain above the chest level. And next is the tubing should have a node link or obstruction that may inhibit the drainage. Traditionally, many patients used to say the milking of the drain, but nowadays the evidence supports that this milking should be avoided because milking of the chest drain always leads to the tension pneumothorax. Until unless if it is specified by the physician, milking should not be done. If there is evidence of clot is there, only such condition with the written prescription or with a verbal prescription, we can go with the milking. Otherwise, milking is contraindicated. And again, mostly sometimes doctors will say connect with the suction. As for the order, how much is the patient, whether suction is to be, if it is suction, it's not simply is it whether patient needs a suction drainage means we have to, it should be prescription by it should be written in the case sheet. And notify the medical staff if it is a continuously draining patient which suddenly stopped draining, whether whatever the reasons, is it a hemothorax or it may be the pyothorax, if it is not draining, and auscultate the lung sounds and patients, and it has to be intimated by to the consultant, and check air leak and oscillation movement. This oscillation movement is indicating the tube functioning. If this oscillation movement is not there when you are taking a round, always you can ask the patient to cough it out. When the patient is cough it off, there will be a bubbling of the fluids in the intercostal that has to be checked. And very often when we shift the patient from one ward to the diagnostic or from the diagnostic to the ward, very often we try to clamp the tube. It should not be done. Do not clamp the tube. You have to entrust to the attenders that not to raise the drain above the chest level, but do not clamp the tube. If you clamp it, what may be the indication? If it is for the tension pneumothorax, the tube is being inserted, that leads to the emergency. The patient may go for the hypertension. So that there is no evidence of the continuous routine dressing change. But however, whenever there is a contaminated, it can be removed on need basis. The next about the common other procedures are the biopsies. Post-kidney biopsies, very often we expect the patient may have the internal bleeding, that is especially from the kidney in the 3 different areas, either in the capsule or the perinephral area, it may be get collected. So always the strict bed rest. Nurse must ensure in the post-kidney biopsy, strict bed rest with a frequent observation for the minimum of 6 to 24 hours. Generally, patient will not be discharged immediately. They will be advised for the 6 bed rest and it will be observed in the post-procedure room. If the low-risk patient can be discharged within 6 to 8 hours if they don't have any symptoms. And observe for the macrohematuria, because this is a very common complication when there is kidney biopsy. So this is usually self-limiting, so bed rest is required. If this hematuria is continued for the more than 24 hours, patient has to be instructed to come back to the physician or to the office. And also, there may be some form of the urethral bleeding. Usually that will be self-limiting within 1 or 2 days. The main thing is here, the nurse should not discharge the patient following the kidney biopsy. The patient is supposed to be observed for the initial 6 hours for the hemodynamic stability to monitor for the internal bleeding. And post-liver biopsy, again post-liver biopsy, usually post-liver biopsy, once the procedure is over, the patient will be asked to lie on the right side. And again, to look out for the internal complication, vital monitoring is very much important. And during once the patient is hemodynamically stable, the discharge instruction can be given, avoid weightlifting and anticoagulants to be avoided because that leads to the bleeding. And patient can come back, the ward nurse can notify any symptoms to the particular consultant in charge. Another important procedure is the LP, lumbar puncture. Following the lumbar puncture, apply brief pressure to the puncture site. Again, the patient is instructed to flat on bed for the minimum of the 4 to 6 hours, and head should not be elevated, because when the head is elevated, there is a chance that CS of leakage will be there. And assess for the Glasgow Coma scale and also vital signs. And what was the purpose? What was the reason for the LP? Whether the particular sample has been shifted, transported to the lab, that has to be ensured. And monitor for the puncture site for the signs of CSF leakage. Mostly the patient will complain of headache, that has to be monitored. That will be settled down with the paracetamol. That is very common complication which is expected following the LP. And encourage the increased fluid intake that will replace the CSF which is being removed. And administer analgesia, because as I said, the headaches are common following the LP. So this headache can be managed with the paracetamol. And the various kind of aspiration from that is either the bone marrow aspiration or the percutaneous aspiration. If you see the bone marrow aspiration, mostly in the flat bones, which is the aspiration is being taken for the rule of the various diagnosis. So after the aspiration is over, the cover the site with the sterile dressing. That is very much important, sterile dressing, and help the patient to any position, that is whichever the bone is punctured, that may be the comfortable position, and properly label and promptly transport all the specimen. And assess the post-procedure pain and advocate the patient for the analgesia, because patients will have the pain. So appropriate analgesics may be given, and patient also may be taught for any signs of infection in the puncture site. And if you look at the aspiration, the percutaneous aspiration, either that can be the thoracentesis or maybe the breast, again, same like that, the puncture site, the wound care, that has to be taken care. If the patient has received a general or the local anesthesia, the vitals to be monitored. That is especially if it is general anesthesia, the vitals to be monitored every 15 minutes for the initial 1 hour and every 30 minutes for the 2 hours, and following that, maybe the 4 to 6 hours it can be. And instruct the patient, if it is a breast aspiration, instruct the patient to wear the support bra at all time, because the sagging which will lead to the healing. So until the healing is complete, the patient is instructed to wear the supportive brassiere. Okay, observe for any report bleeding, tenderness and redness at the biopsy site. So this is the post-general, any kind of the procedures. I have prepared a checklist. This can be applicable for any kind of procedure. The first thing would be of the identify the correct patient using the 2 identifiers. What was the procedure was posted for the patient, what procedure was done, it was the same patient. That has to be checked. That is identify the correct patient using the 2 identifier. and confirm the patient, that's what procedure performed, and whether informed consent forms are available in the chart. Usually that would have been got it before the procedure itself. Is it once you receive in the post-care unit, whether the informed signed consent forms are there, that has to check it, and confirmation of the medication to be continued. Mostly when the puncture is being done, antibiotic prophylaxis will be there, or previous even old medication will be continued. Very common due to the puncture reasons, antibiotic prophylaxis, what prophylaxis is there in the institute protocol, that has to be checked it. And specific care, because we have the different list of procedure, the specific care, if it is especially for the cath lab procedure, the immobilization, that too for the arterial puncture, it is a minimum of the 6 hours, venous puncture, minimum of the 3 to 4 hours. And what is a specific procedure-wise specific care to be followed, and procedure specimen, confirmation, labeling, and transporting to the laboratory, and advocate for the analgesia. It's not necessary the patient has to suffer in pain, and also advocate for the strong, whatever the patient comfortable analgesia, so the pain period will be decreased. And puncture site to be assessed for the bleeding and hematoma. And if any IV fluids to be continued, that has to be taken in the order. So this is about the post procedure. With this, I thank the team once again for the giving opportunity. If any queries, the forum is open now.
Thank you, Dr. And thank you all the three resource person. I know the topic is very big. We had to rush through so many things, but I hope the important points are covered by all the three speakers as pre, intra, and post. So as a concluding remark, I would like to say, prepare and prevent, repair and repent was the right word which was used by Mrs. Sophia, who rightly said we need to prepare every nurse who's taking up the post, maybe a novice nurse or an experienced person who may tell and the next person would look into. Instead of pushing our responsibility into somebody, it is very, very important that we, in every step, maybe it's a daycare procedure or an inpatient procedure, any person who steps into a hospital undergoes an invasive procedure. So this happens to every person who comes into an outpatient and an inpatient department. So as nurses, how important it is for each one of us. Maybe we have seen so many checklists. Are we ignoring all those things which is there in the list? Or have we got it by heart where we just like that tick mark things which would have happened or missed out to check whether it has really happened. So I would like to highlight here on certain things like the verification band, which happens at different hospitals in different ways. So if our hospitals are not really upgraded, so how are we referring into the ID of the patient? So checking on the patient, getting the consent. Now, when it comes to the consent, is it the responsibility wholly lies on the nurse? So it is not we alone. It is the person who is doing the procedure who has to highlight on what the procedure is, at what time, and how is it going to be. That's the responsibility of explaining by the physician who's going to do the procedure. And it is along with the physician we get the consent. So it is not just like that pushing in a paper into a patient and telling them to sign for all procedures which is going to happen, but explaining the procedure is very, very important. The second thing is checking into the contraindication. Okay, we have checked on the previous day, that particular morning, there is something which is happening to the patient. The nurse can stop the patient, stop the procedure immediately. Make sure that the communication is really done and the procedure is shifted to the next day. And the same thing, what has to really happen is adequate equipments at the place. Say, for example, the needle is blocked or there's a problem. And I have seen procedures happening at labor rooms where we have the forceps. You know, you have a tray and you find that two different handles of the forceps are there, and making sure before the procedure that you put the forceps together, or when it comes to a vacuum cup, it gets slipped off. So do you have different size of vacuum cups which is available? So as a nurse, we need to be very much vigilant and aware of certain things which can happen with our experience, and making sure as preceptors, we make sure a novice nurse who is there is also being alerted and not looking into the things may happen. And especially when it comes to the post procedure, you know, a lot of things which we need to observe. Sometimes we say a big sigh of relief when a procedure is over and the patient is shifted, and we are busy documenting. And with NABH coming in, you know, we are many times our hands-on or our soft touch to the patients are lost, and that is very, very important. I want to enforce and say, every nurse, make sure your attention is to the patient, and along with that, after the patient is made comfortable, go into the documentation. So immediately shifting into replacement and documentation, everything is done, and making sure that the patient is aware of facts is again not the right way. So communication is the key need of the hour. We always say, as empowered nurse, we work as a team. When we work as a team, we are a matured group of people where we need to make sure that when a correction is given, take it in the right perspective, and do not take it in the wrong way and become emotionally upset to move people. When people blame at you something, look into that matter, correct yourself. If you are right, speak out. If you are wrong, accept it. And it's always, when we keep talking about our patient safety, it is very, very important to know that we as nurses need to be in the right track, have a right understanding, and as a team, when we come together, not blaming somebody, how can we repair that particular task, or how can we bring it into light, the right fact which has to happen. That is very, very important for as a nurse to be you know, in the right track. So I hope the sessions was useful from the Tamil Nadu chapter. So over to Leena, do you want to add up anything? If not, over to Dhanlakshmi for the vote of thanks.
Yes, ma'am. Dana, please complete it quickly. We are about to start another meet.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Nandri Marapadu Nandrendra. A very warm good afternoon, namaste, vanakkam to all nursing experts, friends and students. I am Miss Dhanlakshmi, Annie Tamil Nadu.
Medicine check pani vaanga.
Annie Tamil Nadu Secretary. On behalf of Annie, proposing vote of thanks for the successful completion of this webinar. First of all, let me thank our Annie, Association of Nurse Executive India, renowned crown, successful and motivation leader who is none other than Ms. Thangam Gomax, President, Founder, Annie, for the opportunity has given the Tamil Nadu chapter to conduct this wonderful Annie Empower our webinar. Ma'am, your leadership and vision always work as an impulsion to do things in different way. Thank you, ma'am. I express my deep sense of gratefulness to our mentor, Dr. Jyoti Clara, ma'am, Vice President, our advisor, her relentless effort in setting higher goals for us to achieve, and her excellent guidance, caring spirit, support, and valuable suggestions. Your encouragement and support means a lot to us, ma'am. It is my immense pleasure to thank Ms. Subhada, Annie Secretary, Ms. Ajita, ma'am, Annie Treasurer, for their support in successful conduction of this webinar. Thank you, ma'am. A person who holds excellent job chairing our specialist panel at Multimodal. Yes, my sincere thanks to the moderator, Dr. Rosalind Rachel, for her in-depth knowledge of the subject and approachable style made the session very engaging and interesting. Yes, ma'am. Thank you, ma'am. I express my deep sense of gratefulness to our eminent speakers, Ms. Sophia Lawrence and Ms. Janagiram Santi and Dr. Lakshmi Ramamurthy, for sharing their knowledge and experience on patient safety and invasive procedure with us. I'm sure that our participants must be benefited. Really amazing to hear the contented talk. Yes, ma'am. Thank a lot, dear ma'am. I would fail in my duty if I forget to thank our office bearers, Ms. Leena Chandrasekharan, Annie Tamil Nadu President, Dr. Rosalind Rachel, President, Annie Tamil Nadu Chapter, Mahalakshmi, Membership and Engagement Committee Chairperson, and Ms. Hena, Annie Member, for their sincere and energetic support made the successful completion of this webinar. A note of thanks to all the participants for their cooperation and willingness to participate in this webinar. And I'm so thankful to all who helped for this webinar directly or indirectly. Once again, thank you all for your active participation. Have a good day. Stay safety and stay healthy. Thank you very much.
Thank you, Dhanlakshmi. Thank you all for participating.
Thank you. Thank you so much.
Thank you. Thank you.